Let's look at the Gangnam aesthetic video in Korea. The old approach was simple. We just filled volume superficially. This often caused sagging and frozen look over time. Now the focus is different. We focus on structural restoration. When structure is restored, hollowness improves and facial expression stays natural. Before we talk about discuss structure, we need to think about time. The face is not static structure. It is continuously changing over time. So any structure we create must last over time. Therefore, we need to move from traditional 3D anatomy to 4D anatomy by adding the concept of time. So today, we will focus on structure and how it changes over time. To understand facial structure, think of a tent. Fibrous tissue acts as a pole, providing support. Soft tissue forms the tent cover. Deep fat compartments are space surrounded by fibrous tissue. They allow smooth movement of the overlying tissue. In the old approach, we simply filled superficial soft tissue like putting weight on a tent cover. It reduced the facial expression and caused gradual sagging. Let's look at photo far left. Before higher lace, the face looks heavy. After higher lace, it looks lighter and more natural. Now look at the smile. Before, it is stiff. After higher lace, it becomes natural and dynamic. So superficial filler can sag over time and make facial expression look unnatural. It can also be identified with a simple pinch test. Currently, we focus on deep structure. We target fibrous tissue and deep fat compartments. Fibrous tissue acts as barrier and keeps filler in place. This fibrous tissue is the key factor for natural long-lasting result with less volume. This concept is applied in G-code. In G-code, L points represent key fibrous tissues. You can think of them as pore in a tent structure. Using this concept, even 0.1 cc per point can create a long-lasting lifting effect. Because we target fibrous tissue, we use a needle to inject filler. As you can see in this image, using a cannula can damage fibrous boundaries and create tracks through which filler may migrate. So it is better to use needle. Because of these advantages, needle use is preferred. However, a needle carries a risk of intravascular injection. So aspiration test is always necessary. Be careful. A filler-filled needle may block blood return. This can lead to false negative result. For a reliable test, use a non-prefilled empty needle. So, is the injection with a needle enough for natural and long-lasting result? Unfortunately, the answer is no. Now let's look at some examples and compare long and correct approaches. Let's begin with the forehead. Recently, Hermes forehead has become popular in China. It creates a more three-dimensional forehead contour. Let me share a case. The patient wanted more forehead projection. I used Hermes technique. 0.1 cc per point down to the bone. Using a needle, I targeted areolar tissue with bone contact. Because the areolar tissue is loose space, I expected it to spread, but 1 week later, the bumps were still there. It improved only after strong self-molding. So I asked, why did this happen? In thin area like the forehead, vertical needle injection can backfire. Because of the bevel length, filler can overflow into the subcutaneous layer. The subcutaneous layer is rich in fibrous tissue, so the filler gets trapped, forming bumps. It does not spread easily. Here is another severe case. So, how can we avoid this? The first method is using bevel down with a lower needle angle. This allows easier access to the areolar layer. It also reduces the backflow. However, with a lower angle, precise targeting becomes difficult, making it harder to inject exactly where intended. The second method is deep pinching technique. With vertical needle injection, deep pinching expands the areolar layer. It also reduces the backflow, and with the vertical injection, we can target the exact point. What you need to consider is not just the depth. As you can see here, the forehead is divided into anatomical compartments by fibrous tissues. These act as a natural wall that keeps filler in place. To keep filler in place over time, we must respect anatomical boundaries. Aggressive cannula movement to even out filler can damage these boundaries. Without fibrous boundaries, filler may migrate. So both depth and fibrous boundaries are essential for long-lasting and natural result. Now, let's move on to mysterious temple. Temple filler may seem to disappear suddenly. Where did the filler go? It doesn't disappear. Deeply injected filler can reappear as a bulge in front of masseter. The temporalis muscle originated from the bone, so even with the bone contact, filler may be placed within muscle fiber. With repeated muscle contraction, the filler can be displaced. It may then move through the buccal pad and form a mass in the anterior masseteric region. Therefore, do not over-inject low viscosity filler in the temporal area. Now, let's shift our focus to the soup. The soup, suborbicularis oculi fat, is a deep fat compartment located in the prezygomatic space. The left image shows filler in the lateral soup. The right image shows the result after hialase. After removal, the face looks narrower and slimmer. Excess filler in lateral soup can make face look wider. So, how does this happen? The soup sits in the prezygomatic space, but this space is not closed. Filler can migrate through the temporal tunnel to the inferior temporal compartment. So, lateral soup filler tend to spread laterally rather than adding projection to the infraorbital area. That is why the face appears wider over time. As you can see here in this image, filler injected into the lateral soup is actually found in the inferior temporal compartment. The key takeaway is this. The prezygomatic space and inferior temporal compartment form one continuous compartment through the temporal tunnel. Therefore, in soup treatment, be aware that the face may appear wider due to filler spread. Superficial or excessive soup filler can obstruct the lymphatic flow and cause malar edema. This phenomenon is more commonly seen with high G prime filler, like radius. Because multiple issues can arise in the prezymatic space, I rarely use it in my practice. Instead, I prefer deep nasolabial fat for mid-face rejuvenation. To correct infraorbital hollowness, we target the DNL in the premaxillary space. It is semi-open space with important nearby vessels such as dorsal nasal vein, facial vein, and angular artery. So cannula injection is essential for safety. However, excess cannular fanning can create tracts and lead to filler migration. So minimum fanning is recommended in this area. In the palpebral malar groove correction, filler injected into the bilamellar ORL, orbital retaining ligament area, can become trapped. Even small amount of filler can form sausage-like bulge. This should always be considered. Now, let's move to the transverse facial septum. It plays a key role in smile dynamics. Look at that. Let's compare these two. Left side, the smile is steep. Right side, at the higher legs, it looks natural. So why does this happen? The key muscle for smiling is the gyromaticus major. It is connected to the bone by the transverse facial septum, in short, TFS. So, when filler is injected into the TFS or nearby compartment like DNCF or DLCF, it can restrict the movement of G major. As a result, the smile becomes steep and the face may look uneven during smile. This is also seen on ultrasound. Anechoic filler around the G major can block its upward movement. So smile becomes more horizontal. At the higher legs, muscle movement is restored and the smile becomes more natural. This effect even extended to the lower face. A horizontal smile can push down the chin, leading to dynamic poses. So when injecting around the TFS, use only the small minimal amount. Next, nasolabial fold. When treated well, it improves the facial aesthetics. But in injection, if injected improperly, it can worsen over time. Take a look at this case. After cannula injection into the deep piriform space, a palpable mass developed near the cannula entry point. Here. This happens because filler flow back along the cannula track to the entry point. To reduce backflow, target the peri-alar space or sub-alar space that Professor Hizuki already mentioned, which is deeper than the deep piriform space. With a cannula, you may need a pump as it passes through muscle or fibrous tissue. This may help reduce backflow. However, remember, any puncture in the fibrous boundary can become a pathway for migration. To prevent migration, I prefer use a needle to target the peri-alar space directly. In the lower two-thirds of nasolabial fold, superficial subcutaneous injection may initially appear effective for smoothing. But lip elevator muscles keep contracting. They compress the superficial filler and push it toward the nasolabial fat. so the fold can look deeper over time. That is why we avoid superficial padding in the lower nasolabial fold. In this patient, I use just 0.3 cc into the each perialar space using a needle. The lower two-thirds of the nasolabial fold improved with lateral lifting factor. With just 1.5 cc per side, we achieve immediate improvement. Now, the final key area, the buccal mandibular space, or in short, BMS. In pre-gyral sulcus correction, as described in the paper by Professor Hee-Jin Kim, the BMS is key. Deep needle injection in pre-gyral sulcus can cause lateral migration through the BMS. The main issue in pre-gyral sulcus is skin thinning and subdermal volume loss, so a superficial pendular approach is better than deep bone touch injection in pre-gyral sulcus correction, in my opinion. As we have seen, simply injecting deeply with a needle is not the answer. A precise understanding of area-specific anatomy and techniques is essential for maintaining natural, long-lasting results. Thank you for your attention throughout this long lecture.